Okay, perfect. Thank you. Hello, everyone, and welcome to our webinar today. My name is Gil I, and I am the Senior Director for Patient Education. And I'm sorry, I'm trying to do two things at once. I'm going to share my slides. 1 second. Sorry about that. They closed.
No worries. Take your time.
Let me share. Meredith, I'm going to ask you to share the slides because I do not have them coming up. I'm gonna send it to you really quick. Actually, let me send it to you, Mike, because you seem to have permissions that I do not.
Certainly.
Sorry about that, everyone. 1 second, we'll be ready.
Not a problem. Technology issues happen.
Do you think I'll be able to open the slides that I have ready to go? Should I test them real quick to make sure?
Well, you will.
You should be. You should be.
I'm going to test it.
Go ahead. If you want to pull yours up, you go ahead.
All right, good.
You know what? I'm just going to read my slides. I'm just going to go ahead and read my slides, and you keep your slides up. So I am going to introduce Dr. Wolfe today. Dr. Wolfe will be speaking to us on a new treatment for MG. Dr. Wolfe is the chair of the Department of Neurology at the University of Buffalo School of Medicine and Biomedical Sciences, the State University of New York. He is also the Dr. Bob and Jean Smith Foundation Distinguished Chair in Neuromuscular Disease Research. His interests in neuromuscular medicine are wide, but have mainly focused on myasthenia gravis and other disorders of neuromuscular transmission, as well as peripheral neuropathies. He is board certified both in neurology and neuromuscular medicine. He is also board certified in neurophysiology and performs electromyography and nerve conduction studies and monitors intraoperative evoked potentials for spine surgeries and other operative cases. He remains actively involved in training of younger physicians and has directed neuromuscular medicine and the clinical neurophysiology fellowships and neurology residency training programs. We do want to thank our sponsors today for this series. Our national presenting sponsors are Alexion, argenx, and UCB, and our national sponsors are Horizon and Advanced Neurosciences. So Dr. Wolfe, we are ready for you, and you can go ahead.
Okay, great. And I just want to make sure somebody give me a thumbs up. Dova, give me a thumbs up if you can see my slides. You do? Okay. And people can hear me as well. Great. Okay. Well, I'd like to thank Dova, thank the Myasthenia Gravis Foundation of America. It's just a great organization. I was communicating earlier today with Sam Masterson on some work that we need to do next year. But, you know, an organization that really focuses on myasthenia gravis and closely related conditions. And, you know, these seminars, I think, are great for patients and their families and for us, too, because we get to hear from you and rethink things sometimes. But I'm going to talk about not the newest now, but nearly the newest agent that's been approved for myasthenia gravis, and it's called Rystiggo. It's rozanolixizumab noli, which is a little bit hard to say. People often will just shorten rozanolixizumab to Rozumab, just so you know. The reason I'm saying it's nearly the newest is because, honestly, in the last week, I think it was 4 days ago, UCB, the company here, also had another drug approved for myasthenia gravis. All these 5 drugs that are approved are for generalized myasthenia gravis. There's slight differences in the approvals, though, and I'll get to that specifically with rozanolixizumab noli, with Rystiggo, because it's the only one that's approved also in MuSK myasthenia gravis, and we'll go through some of that data. But anyway, this was recently approved earlier this year. It is the second agent with this particular mechanism of action we'll get to, called FcRn antagonism. So I hope that's a good start. There's only 32 slides. I'm going to try to get through them as fast as I can so I can answer a lot of questions. All right. So this is the first FDA-approved treatment, as I alluded to a moment ago, for both acetylcholine receptor antibody positive MG, which is the majority of generalized MG, but also anti-MuSK antibody positive MG. Okay. It's a subcutaneous infusion, so it does involve a needle. It's weekly for generally 6-week cycles, similar to how other FcRn antagonists have been approved. They're these cycles of therapy, and it's given weekly. It's a single needle, okay? And we'll get to the safety stuff that's at the bottom of the slide later, okay? So what is it indicated for? It is indicated for adults over age 18, basically, with generalized myasthenia gravis, again, either receptor antibody positive or MuSK antibody positive, okay? Realize this is an immunotherapy. All of our immunotherapies can potentially increase the risk of infection. This can also cause aseptic meningitis. So what's just to, I think many of you on the call are familiar with myasthenia gravis. But just a few disease state slides to get us started. It is an autoimmune disease. What does that mean? It means that the immune system is attacking itself. And in fact, myasthenia gravis is one of the better understood autoimmune disorders. We know exactly what's being attacked in most cases as far as a specific antigen. For instance, the acetylcholine receptor or MuSK, which is also on the muscle membrane. It's chronic. This is a lifelong potential disease. It's a chronic disease. Immune system, that's the system mainly composed of humoral and cellular factors that protect us from infection and disease as well. For instance, cancer. Our immune system helps fight off malignancy as well. So it's very important, but it's awry in patients with myasthenia, or in patients with lupus, or in patients with autoimmune thyroid disease, or in patients with rheumatoid arthritis. But myasthenia gravis is one of our better understood autoimmune diseases. Not that it's the most common, but it's pretty well understood. Generalized myasthenia gravis, there's really two major clinical types. We have generalized disease, and all the 5 drugs have only been approved in generalized disease. I just want to say that up front. There's also pure ocular MG. It's less common. Most MG is generalized, if not initially, over time, usually within the first year or two, generalized symptoms do appear. What does that look like? Muscle weakness and fatigue, but it can involve things like chewing or breathing or arm and leg weakness, making climbing stairs or even shampooing your hair or brushing your teeth challenging. And I think you all know it is our classic fatiguing disease. Fatigue can occur in many different neurologic diseases, such as Parkinson's disease. I mentioned this before. Somewhere around 95% of people who have generalized MG are either going to have acetylcholine receptor or MuSK antibodies. The remainder have perhaps LRP4, which is very rare. That's a very rare antibody, or are just simply seronegative, where we cannot detect a specific antibody despite a bunch of different blood tests. Now realize, in addition to receptor antibodies, MuSK antibodies, we've seen antibodies, again, I mentioned the LRP4, quite rare. There's a few others that are thrown in there, but the main ones we can commercially test for are receptor antibodies, that's acetylcholine receptor, AChR, the MuSK, and LRP4. Okay, this is our neuromuscular junction on the left. I don't know if you can see my arrow. I bet not, but you can see the nerve at the top in blue. You can see the muscle membrane in the bottom in yellow with those nice folds, those kind of crevices. The little black dots are the receptors, okay? And the little asterisk-y bluish things coming out of the nerve, that's neurotransmitter. Here, we're specifically talking about acetylcholine, okay? Is a neurotransmitter at the neuromuscular junction. This is what it looks like normally. If you impair neuromuscular transmission, this sequence of events, going from nerve to muscle, you will lead to weakness, okay? And see here some important terms on the right. Again, the neuromuscular junction is a connection between the nerve and the muscle. If you look at the muscle kind of like a light bulb, the nerve is kind of like the wire that feeds that light bulb. And the light bulb going on would be contraction of our muscles so we can generate strength, okay? Neurotransmitter is a chemical signal that carries information from the nerve cells. Again, in this situation, it's acetylcholine, and the receptors are proteins in cells, usually on the surface, though, that actually receive the chemical signals, okay? And here, it's primarily the acetylcholine receptor. Now, realize acetylcholine does not directly interact with MuSK, but MuSK does interact with something else through another receptor called a nerve-derived aggrin. And it's crucially important, that sequence of events going from aggrin to LRP4 to MuSK, that enables proper scaffolding and proper formation of the neuromuscular junction on the muscle side. The end plate is what we call it. So if you interfere with that MuSK-related phenomenon and sequence of events, cascade of events, you will also mess up neuromuscular transmission. I just want to mention that because there's not really a great figure for that. Here are antibodies. These could be to the acetylcholine receptor or to MuSK. The antibodies are these reddish Y things. Why are they Ys? Because that's what they actually look like on high magnification. They look like Y structures. There's an FC and FAB portions. I don't want to get into that. But what I want to get into is if you look at the two Ys on the left here, the one furthest on the left, that could be an antibody that's simply just blocking the acetylcholine receptor itself and preventing proper ion transmission so we can excite the muscle membrane. It's sodium entry, but I don't want to get too far into the weeds here. The one in the middle, you can sort of see it. If you can cross-link two acetylcholine receptors, two of those dots, one way that acetylcholine receptor antibodies cause the disease is they actually reduce the number of receptors. If you cross-link two of them, they actually will internalize and go into the muscle, okay? And so you have fewer acetylcholine receptors there to help us transmit the signal from the nerve to the muscle. Antibodies on the right, it's a part of our immune system. When acting normally, they protect us from foreign substances such as viruses and bacteria. When you get a vaccine, you're hoping to build up antibodies like when we get the COVID-19 vaccine or the flu vaccine, for that matter. Now realize the therapies, most of these, not all of the approved therapies, but most of them are also antibodies. They're monoclonal synthesized antibodies to do certain things, and we'll get to that in a little bit. Okay, so how does it work? We got to it right away. How does this work? Okay, here we see again our antibodies. And let's pretend that this antibody is made to the acetylcholine receptor, okay? The FcRn mechanism, that's also known as the neonatal Fc receptor. It's on many cells, but it includes endothelial cells, the cells that basically line our blood vessels. This mechanism allows IgG molecules to persist for weeks, about 3 to 4 weeks in our body, okay? If this antibody connects with that F-ish, that F-looking molecule, which is in yellow, if it makes a good connection and binds, it will get recycled. The whole process that we're doing with FcRn antagonism with a drug like Rystiggo is to block that binding, to prevent the binding of that orange reddish antibody to the yellow neonatal Fc receptor. Because if we block that binding, what we'll end up with is at the bottom here of this cell figure, this circle, you will degrade. If there's no binding, that antibody will be degraded. And that's a good thing. If we can degrade disease-causing antibodies, we'll have less of them and we'll have potential improvement in the disease state. And that's what we've seen with the trials of these types of agents, okay? Now, why I want to just mention IgG specifically is because every single form of myasthenia gravis that we have identified that is connected to an antibody, it is an IgG antibody, okay? It's an IgG antibody. Realize this system has nothing to do with IgM or IgA or IgE. It's specific for the IgG system, okay? Because, but I'll just throw this in as an aside, that is why the half-life, the survival of these other immunoglobulin molecules that also can help us fight infections and are involved with allergies and things like that, their half-lives are days, not weeks like for IgG. So now moving on, Rystiggo, that green, again, it looks like an antibody because it is. It looks like a Y because it is. It's blocking that interaction of the red and the yellow. And because we don't have the interaction of the red and the yellow, the antibodies are broken down, okay? Now, yes, you may be thinking, well, does that break down other IgG molecules? It does. This is pretty much a class effect across IgG 1, 2, 3, and 4. That's why there is a susceptibility of potential infection, because it's also removing IgGs that may be doing good. The ones to acetylcholine receptors are not doing good, but there's a lot of IgGs that are doing good, and it does reduce those as well. Not 100%, but somewhere in the 70–80% range. Okay, let's move on. So what were the results with the actual trial? And so, trials are complex. This was a complex trial like most. Patients, 200 patients were randomized to either placebo or 7 milligrams per kilogram or 10 milligrams per kilogram of the active drug in equal aliquot, so a third in each. So you ended up with about 66, 67 patients in each group. And again, as I mentioned before, they received one dose every week for 6 weeks, and then they underwent an observation period of up to 8 weeks to see how they were doing. And patients could be retreated with a subsequent cycle, okay, beyond that period of time. But the primary outcome was done at a day 42, after that initial cycle of 6 weeks. 6 times 7 is 42. It was actually day 43, but anyway, basically 6 weeks. Okay. And it included both receptor antibody and MuSK antibody positive patients. What was seen? Significant improvement in the MG-ADL. That is an 8-item scale. I wrote the first paper on the MG-ADL back in 1999, a quarter of a century ago now. But anyway, it is the outcome measure that the FDA has used as the primary outcome for all of these different drug approvals. And as you can see there, the details are minus 3.4 points with the active drug versus 0.8, only 0.8, not even a full point on the placebo. And that was statistically significant. And just to give you an idea, even a 2-point drop on the MG-ADL is considered of some clinical significance for patients, okay? This rapid improvement was definitely seen by the end of 6 weeks, but even as early as 1 week after the first dose, some patients had improvement that quickly, okay? And what you can see at the bottom is the proportion of patients on the 2 different doses compared to placebo. It was about 35% of patients on the lower dose, 38% on the higher dose, compared to just 24% of patients on placebo who had a significant improvement, okay, based on MG-ADL. All right. What is the MG-ADL scale? Again, I mentioned it's 8 categories. It assesses ocular function, breathing, talking, chewing, and so forth. It's real easy to do. It takes a minute and a half after you're used to it. It doesn't matter if patients fill it out on their own or if it's driven by a healthcare provider. There's a couple of studies that show that. But I actually follow it routinely in my clinic, okay? And then it's also used, as I mentioned, as a primary outcome measure. All right, now this is other data from the clinical trial. So up to 72% of patients responded to treatment, okay? So not 100%, but it was basically 3/4. And that was based on at least a 2-point improvement. Again, I mentioned that 2-point threshold as being clinically significant, clinically meaningful, if you will, on that MG-ADL score. A 2-point drop or greater is considered clinically meaningful. And we got that in 3/4 of the patients. Yes, it was seen in placebo as well, 31%, but that was statistically significant, favoring the Rystiggo as far as the proportion of patients who responded. And then here's the MuSK story. Again, I mentioned there were 12 participants, and all of the patients with MuSK antibodies did improve based on the MG-ADL score, all 12 out of 12. A rare form of MG, but still, it's nice to have an approved agent for the first time in the MuSK population. This is the very first one. It's always crucial, in addition to looking at clinical efficacy, to look at side effects. I mentioned before, infections can be of concern because, again, we're reducing IgG globally here. And IgG is important in fighting infections. You can see, there was a slightly increased percentage of patients on Rystiggo who had, say, an upper respiratory tract infection. You can see, diarrhea was somewhat more common, fever more common. Other things were really quite uncommon, 10% or less, and not a really marked difference in what you saw in placebo. So even on placebo, 19% of patients had some infection. It was just 4% higher on Rystiggo. But it is something that we have to monitor and always be mindful of. Both the doctors and patients and your families need to be mindful that there is that potential risk. There is no vaccination that is required before this agent, if you were wondering about that. So Rystiggo may increase the risk of infection, as I mentioned before. I won't go through that any further. Aseptic meningitis, what is that? These patients look sick. They don't have an actual bacterial or viral cause of meningitis. That's why it's called aseptic. It's a chemical type meningitis, but they can look very sick, even have some fever, a stiff neck like you get with bacterial meningitis. It is possible. I haven't seen it with this class of agents, but it is potentially possible and has been reported. Just excuse me for 1 second. Hypersensitivity reactions, swelling and rash, that can occur with just about any infused medication. There are potential allergic reactions and so forth, so those need to be kept in mind as well. If you're planning to become pregnant or are pregnant, so the FcRn agents, the FcRn receptors were actually first described in other tissues like the mammary glands, and also in the placenta to actually transfer IgG to make sure it gets transferred over to the neonate or the fetus. And so if you are pregnant, these types of agents can interfere with those types of processes, which would not be advantageous for the baby. So you need to let your healthcare provider know. Plus, the true safety of these agents in pregnancy is not clear yet. Hopefully, over time, we'll be able to determine that with greater clarity. Okay. You need to talk about other medications that you might be on. The most common side effects, again, were headache and infections and diarrhea. Okay. So what to expect with Rystiggo? As I already mentioned, it is a infusion, but done subcutaneously. A single needle is inserted just under the surface of the skin. It's generally done in the lower abdomen area. You do have to get monitored. It has to be done in some kind of healthcare setting with a healthcare professional. That's how, so far, these sub-Q infusions, not just for this agent, but for other agents, is being done, at least in the MG theater, okay? But it's pretty quick, and again, it's weekly for 6 weeks. So there it is. The first treatment cycle is 6 doses once weekly, and then you're sort of seeing how patients look, okay? And what you can see here in a long-term extension study, okay, in gray inside that box, the minimum length of time between the start of treatment cycles was 9 weeks, okay? So that would have been about 3 weeks and after the 6-dose weekly cycle. But other patients can go quite a bit longer, okay? And do realize, as the label says, the safety of starting later cycles sooner than 63 days from the start, from that very first infusion of the prior cycle, it's not established, okay? So I don't think you're going to see doctors really, doing this, at least from the information that we have right now, in any kind of cycle faster than 3 weeks after finishing the prior cycle. That's the main message to get across here. Most people may require repeated cycles of Rystiggo to manage their GMG symptoms. These agents don't last forever. You will see the IgG levels and even the acetylcholine receptor antibody levels start coming back to baseline, increasing several weeks after those cycles start. So the supposition is, repeated dosing is going to be needed in some fashion. But again, how frequently those cycles have to be repeated, that's going to vary and will have to be individualized per patient, okay? So it's important to track your GMG symptoms that may return during breaks from treatment. Be sure to discuss them and then, make plans and decide how you're going to schedule this. That's going to be a two-way street between the doctor or supportive staff in the doctor's clinic and you, okay, to exactly figure out how many cycles are going to be given, say, in a year's time, okay? But that's nice in a way, even though there's some uncertainty about that. It's nice in a way because it really can be individualized. So you can actually gauge that and determine that over time depending on patients' responses. I already mentioned about infection risk. If you have an active infection, you should hold off before you give this medication and treat that infection. I would not feel comfortable giving this agent or really any of the other approved agents at this point in time to a woman who is pregnant. Onward. So this is the name of a support system that is provided by the industry, by UCB, to help patients. And there's a website there, ucbonward.com. Pretty easy to remember. Again, I'll repeat it, ucbonward.com. There's also that phone number there. Obviously, you can go online at any point in time. The calls have to be Monday through Friday during business hours. But what does Onward have? A medically trained coordinator, tools and resources to help you get started or to continue therapy, insurance coverage reviews and so forth, and guidance and symptom tracking and ongoing treatment support. It's all built into this support system that is sponsored by UCB. So how do you talk to your doctor? Excuse me, just for one moment. You know, I often get a question from patients, especially early on in their disease course with MG. What should I look for if I'm getting worse? Sometimes it's the same symptoms that you presented with. Sometimes it could be slightly different symptoms. And so it's important to have some appreciation of the different types of things that can occur in myasthenia gravis. And that's why handing out information from the Myasthenia Gravis Foundation of America, where they have pamphlets and online materials that describe MG, is really, really important. Also, the drugs that you should avoid when you have myasthenia gravis. The MGFA has all those types of resources, and they're easily accessible, and they are free, okay? How will I know if any new symptoms are related to GMG? It can be difficult if it's just a fatigue element, for instance, and the patient may also have congestive heart failure, for instance, which can cause fatigue, or thyroid issues that can cause fatigue. It can be somewhat difficult. Sometimes even the doctors are not completely sure, but it's always best to check in with the doctors, their nursing staff, and so forth if you're worried. What do I need to consider as far as what the subcutaneous infusions are like? Yeah, you know, you may get some tenderness right in that area, a little bit of a inflammatory response where you get a subcutaneous infusion. During a treatment cycle, you want to keep track of any side effects and share them with the doctor. You know, track how you're doing. You may do that from the MG-ADL. It's easy to do that on your own. Or just keeping a calendar, you know, after those 6 weeks are over, do you notice some of the symptoms that you had before, even some new symptoms arising? Let us know, because that's going to help us guide how we repeat those cycles. And again, the cycles are 6 weeks. I don't anticipate much short shrifting cycles, saying just 3 weeks. Right now, it's the cycles are designed to be a 6-week cycle. So here's sort of a summary slide. Again, Rystiggo reduced generalized myasthenia gravis symptoms based on the MG-ADL significantly. It also improved objective measures of myasthenia gravis, say from the quantitative MG score. That's a 13-item score that's also tracked in these trials. It works by targeting neonatal FC receptors. When neonatal FC receptors are not blocked, that makes IgG have a sustained lifespan in our circulation, a period of about 20 to 25 days, 3 weeks or a little bit longer. But using antagonists will make those IgG molecules, will degrade them, again, in lysosomes in the cells. That's where they end up getting navigating towards if that interaction between the IgG and the neonatal FcRn receptor is blocked, okay? And that's what this drug and other drugs in the same class are designed to do. And again, it's administered quite quickly, somewhere around 15 minutes, okay?
Well, we thank you very much for your time, and thank you to UCB for this presentation.